So yes, what I was telling is that just before speaking about the impact of gratitude in the specific context of palliative care on patients, I just would like to provide an update of the literature on gratitude-based interventions in general. And because the meta-analysis published last year took into account all the intervention studies with a random assignment to assess their efficacy with the specific regard to depressive and anxiety symptoms. And the intervention included in this meta-analysis were quite varied because they have included gratitude journals, gratitude listing, and also interventions to express gratitude, for example, gratitude letter and the gratitude visit. Importantly, this meta-analysis also assessed the impact of potential moderating variables, including, for example, the type of intervention, face-to-face or online intervention, but also the gender, age, and dosage. Finally, they have included 27 studies with more than 300 participants. And when looking at the results, it's quite interesting to see that the effects are small to moderate, depending on whether you consider anxiety or depressive symptoms, but with stronger results for depressive symptoms. In addition, they found absolutely no moderation effect for all the variables considered in the meta-analysis. And the conclusion of the authors is also interesting because they state, we find limited evidence for the efficacy of gratitude interventions in reducing symptoms of depression and anxiety, and we advise to use alternative treatments. But nevertheless, I would like to point out two major limitations, in my opinion, in this study. First, the fact that they found only 2 studies with clinical populations, and the fact that the outcomes were limited to psychological distress with anxiety and depression. I just would like to say that there is another previous meta-analysis from Davis and collaborators in 2016 that has included positive outcomes, psychological well-being and gratitude, but the results did not differ so much with small to moderate effect size on these outcomes. But the poor information about gratitude in the clinical context is, in my opinion, an important justification to study gratitude in these clinical settings, and in particular in oncology and palliative care. In the clinical field, if we now focus on gratitude in oncology patients, I think that we tend to have more and more studies with encouraging results. The results presented in this slide are not exhaustive, but if we consider first these 2 cross-sectional studies, we find interesting associations between gratitude and intrapersonal resources, for example, post-traumatic growth, positive emotions, less psychological distress associated with gratitude, and also correlations between gratitude and interpersonal resources, for example, the perceived social support. Gratitude interventions are also promising since they seem to improve perceived social support, adaptive coping, and also decrease psychological distress. And in the same line, a recent RCT study from Tan and collaborators also shows the beneficial impact of gratitude intervention on intrapersonal outcome, anxiety, depression, but also spiritual well-being. So with our team here in Lausanne, we were especially interested in gratitude in the palliative care context and with patients. So we conducted a first study to assess if there is a significant association between gratitude in palliative care patients and other important outcomes of palliative care, which are the quality of life, post-traumatic growth, and also the psychological distress. This was a transversal study based on standardized and validated questionnaires. And for the study, we have considered gratitude as a personality trait. I will not go too much into the methodological details, but it was interesting to see that we found positive correlations between gratitude and quality of life, as you can see on the figure on the left of the slide. And we also found negative correlations, significant negative correlations between gratitude and psychological distress. Another interesting result, we found that appreciation of life, which is also a key characteristic of gratitude, but which is also a dimension of post-traumatic growth, was the subscale of the post-traumatic growth inventory with the highest score. The results of this first step study confirm that gratitude seems to be a relevant concept in palliative care, at least for the patients. So in the second step, we thought that gratitude may be used, or it's an hypothesis, but we thought that gratitude may be used as a psychological lever to strengthen quality of life, of course, in palliative care, but also as a potential interesting outcome, including the relational domain. And this was precisely our research question for this step 2. For this second study, we have considered gratitude as an emotional state. More precisely, as another oriented emotion, since gratitude involves not only experiencing a positive feeling and positive emotion, but also to recognize that the source of this positive feeling lies outside the self, and most often it's the people around. So the objectives of this second step study was to assess the feasibility of the gratitude of a gratitude-based intervention, and to explore the effects of this intervention in patients and relatives by considering the quality of the relationship, the quality of life, psychological distress, and the feeling of burden. Just a few words about the gratitude intervention we used for patients and their relatives in this study. For us, it was very important to propose the intervention to both the patient and the relatives, because most of the time in the palliative care, we focus with the psychological intervention either on the patient or the relative or the professional, but it's quite rare to consider both the dyad patient and the relative. And as you can see, the intervention consists in a two-step process. First, we have invited the patients and the caregivers to write a gratitude letter to each other. And second, to share the letter with each other. If we have a brief look at the design, it's quite a classical design for an intervention study. We measured baseline quantitative assessment before the intervention. Then we gave 1 week to both the patient and the relative to realize the intervention. And then we have a second quantitative assessment post-intervention. And finally, at the end, we have also proposed a qualitative semi-structured interview to all the participants in order to have a feedback about the potential facilitators, barriers, but also to explore a little bit more the effect of this intervention from a qualitative perspective. If we look at the recruitment, from the 138 patients informed, only 23 patients participated and completed the study. And it's also interesting to see some reasons for refusal. Among them, we can note the uncomfortable fact to write or to share the gratitude feeling, but also the fear of burdening the relative. If we have a brief look to the quantitative results, it's interesting to see that we found no significant changes in the patients. If we take now the relatives, we also had quite few significant results. We only observed a decrease in the psychological distress in the relative if we consider both the total score and the depression subscale. But for the majority of our outcomes, we did not find any significant results. I come to the results from the semi-structured interviews that we did with the participants. And I just would like to present you a semantic map reporting the intervention effects reported by the participants of who did these interviews with us. There were 15 patients, 15 carers, and 3 interviews with both the patient and the caregiver. Analyzing the data, we have categorized the effects in 3 main domains: emotion, cognition, and also relation. Regarding the emotion dimension, and more especially the positive emotion, we have identified a category that we have named gladness. This category refers to emotion characterized by the general positive valence. For example, I could feel good, I could feel happy, it was pleasant, it was a glad experience. We have also identified a more specific category of positive emotion, referring especially to love and gratitude, reported by the participants, by both participants, the patients and the relatives. But we have also identified negative emotion, especially sadness and anxiety, resulting first from the challenges of the exercise before starting the exercise, but also resulting from the confrontation and the awareness that a lot of positive experiences were definitely lost and or in the past. The openness to emotion category refers to the fact that some people were inspired by the intervention to express and even to practice gratitude after the intervention, and also for other positive emotions. And the fact to be inspired for doing something is, in my opinion, also related with the cognition dimension. Still in this cognition dimension, the personal strengths refer to an awareness that the person holds previously unknown strengths within him or herself. For example, optimism or some resilience abilities. Some participants mentioned gaining greater awareness of the other support, of the other's difficulties, which is also linked with our relational dimension. And finally, some participants talked about the intervention as consolidating the relationship with a relative, even if it was already positive before the intervention. We have also explored the perceived barriers and facilitators when using this kind of intervention with, in the palliative care context. And in terms of facilitator, we have identified 3 main points. First, the fact that to be aware of one's own emotion is something facilitating for expressing gratitude, for writing gratitude, but also for expressing gratitude. The fact to be comfortable with writing as a means of expression, and also the fact to be personally characterized by gratitude as a general personality trait in the daily life. And in terms of barriers, we have identified the patients of relatives with too much physical difficulties, which is quite logical in the palliative care setting, but also the possible confrontation with memories that were unprocessed or not well integrated by the participants. And finally, also the difficulties mentioned by some participants in both expressing and also receiving gratitude. And I just wrote some examples that you can read on this slide. Just some elements of discussions regarding this second step study. We certainly faced a selection bias linked with the fact that the patients recruited are those who are most physically stabilized in palliative care, but also linked with the difficulty to recruit patients with relational dimensions. We have also some hypotheses explaining the difficulties of recruitment and the perceived barriers for the intervention. First, we have perhaps underestimated the importance of culture on reciprocity. It's likely that the feeling of debt and obligation after receiving the gratitude expression is more representative of individualistic societies than collectivist ones, as for example, in the Eastern societies or in the Southern societies. And I think that this can be a break when working with gratitude in the context of palliative care with patients. We have also identified some factors that may facilitate the implementation of such an intervention in the palliative care setting. For example, this kind of intervention does not require a specific training, but for the professional, which is often a barrier when implementing a new intervention in the clinical setting. Another already mentioned facilitator is the fact that this intervention includes both the patients and the relatives, and this point was also mentioned by our participants. And also the fact that this kind of intervention allows some flexibility and creativity. For example, it's also important to offer the possibility to record a message transmitted, and also to offer some help to the participants for writing, some help from the professionals. And just as conclusion now of this talk, I just would like to highlight some reflections in order to better integrate gratitude-based intervention in the palliative care context for the patients. First, one of the problems with positive psychology intervention is, in my opinion, the one-size-fits-all approach. I think we definitely need to more take into account the dose-effect relationship by considering the individual characteristic of the participants, either in terms of personality, but also in terms of potential emotional regulation difficulties. Second, it could be beneficial to combine a gratitude-based intervention with a more classical face-to-face psychological support. This would allow to better integrate the psychological difficulties of the patients, in addition to working on the positive with the gratitude-based intervention. And this would offer, I think, an interesting complementary perspective. By doing like this, it would also allow to provide a containing frame in case of potential negative emotions resulting from such an intervention. And we have seen that this kind of negative emotion is possible. And finally, and also an important point for me, this would allow to more benefit from the patient-therapist alliance or the patient-psychologist alliance, because I think it is worth reminding that the best predictor of the effectiveness of psychological support or psychological intervention is the alliance between the psychologist and the patient. And finally, when working on gratitude, it is also worth exploring other culturally adapted interventions for spiritual patients in order to facilitate and cultivate gratitude. For example, prayer, forgiveness interventions, or other mindfulness interventions.